Welcome everyone. We are looking in this session at how the health data research hubs and the British Heart Foundation Data Science Centre are supporting the COVID-19 research. I'm Sarah Brooke, I'm Deputy Chair of the Public Advisory Board at HDR UK, and I'll be co-chairing the session with Kathy Sudlow, who you'll meet in a minute, who is Director of the British Heart Foundation Data Science Centre. As you can see on the covering slide, we have 3 additional speakers with us today. Ami Banerjee, who is Associate Professor of Clinical Data Science, Honorary Consultant of Cardiologist at the University College London. We also have Jeff Hall, who's Clinical Lead and Deputy Director at DataCan, and Jenny Quint, who is Chief Clinical Officer and Deputy Director at Breathe. Our aim is to spend about 30 minutes for presentations, and we will then, hopefully if things go to plan, pick out a couple of questions at the end of each session, and then we have an additional 10 minutes right at the very end to do more Q&A. So without further ado, I will hand over to Kathy, who will give you a little bit more information about the support that the hubs and BHF are giving to the COVID research. Thanks a lot.
Thank you very much, Sarah, and welcome everybody. I'm Director of the BHF Data Science Centre and very pleased to be here and speaking to you today. Could I have the next slide, please? So as those of you who were attending the earlier sessions will have heard, at whistle-stop pace, Health Data Research UK has established several hubs and a data science centre focused on specific areas of health data science, bringing together collaborations from across the NHS, academia, industry and charities to work across specific disease areas to bring large-scale data sets together, to add value to those and to make them available UK-wide for research and innovation. And several of these hubs have a disease-specific focus, for example, gut reaction, focusing on inflammatory bowel disease, DataCan, which focuses on cancer, Insight, which focuses on eye health and eye data, Breathe, which focuses on respiratory data, and the BHF Data Science Centre, which is focusing on cardiovascular disease. I mean, there are some other hubs which have other thematic areas of interest, for example, emergency care, real-world evidence, or clinical trials. Next slide, please. So just very briefly to give you a flavour of what the BHF Data Science Centre, which was established at the start of this year, is doing. We're working to bring data sets together at scale across the UK to shed light across the areas of thematic activity of Health Data Research UK on the causes of cardiovascular diseases, on clinical trials that will inform better evidence-based care, on improvements to the public's cardiovascular health, and on better care and facilities at the clinical coalface for cardiovascular diseases. And essentially, we're focusing currently on working at scale with data that are structured, that is, data that are coded using classification systems available across the NHS, bringing together data sets that are generic and relevant across many diseases, from secondary and primary care and from death registries, for example, and also data that are specialist, for example, from cardiovascular, stroke and vascular surgery audit systems that operate across the UK. But as we move forward, we will be focusing as well on bringing together data that are unstructured. So data that are not coded, for example, the free text in hospital records, data from images such as cardiac MRI scans or brain images, and also ECG and echocardiography data sets. Next slide, please. COVID-19 has been a great challenge, but also an opportunity for us in the BHF Data Science Centre, as it has for the other disease domain focused hubs, to really move at pace. And the cardiovascular BHF Data Science Centre is doing a lot of work in partnership with data custodians based in the 4 nations of the UK. And on this slide, you can see some of the work we're doing with NHS Digital to bring together data sets across England, both of a generic nature, so COVID-19 test data, intensive care data, secondary and primary care data, death data, community prescribing data, and specialist data sets at a pace which really we haven't seen before, and bringing them together into NHS Digital's first trusted research environment to be accessed by researchers around the UK to try and answer questions about how cardiovascular disease affects risk of and susceptibility to the poor outcomes following COVID-19 infection, and indeed on the other way around, how COVID-19 is affecting cardiovascular diseases both directly and importantly indirectly. Next slide, please. And finally, just to give you a flavour of some of the work we're doing in partnership with hospitals across the UK who've been submitting data to us to demonstrate how cardiovascular services, diagnoses and treatments are being affected by the COVID-19 pandemic. And here are some data just showing broad numbers of hospital admissions across a number of hospitals in the UK, showing how these have changed over time from around about the start of October through to May of October last year through to May of this year, shown in the solid lines. The little yellow humps show the COVID-19 admissions, and the dotted lines show what was going on for the same calendar weeks a year earlier. You can see a dip for each hospital at Christmas, so that dip is occurring towards the end of December, and then you can see a big plummet in the orange lines for each hospital over the time of the COVID-19 pandemic, particularly just before and following lockdown, with some slight recovery towards the end in early May. This is a massive dip that far outweighs the increase in COVID-19 admissions, and it's very interesting to speculate what impact that might have had on the health services, and we'll be doing more work on that and looking at these data for cardiovascular diseases as well. So that's a quick whistle-stop introduction to the BHF Data Science Centre, and now I'd like to hand over to Ami Banerjee, who's been working with us and doing other work with his colleagues on cardiovascular disease.
Thank you very much, Kathy. Good morning. So I'm an academic cardiologist at University College London. My email and Twitter details are there. And we've been doing some work since March, looking at excess deaths and direct and indirect impact of the pandemic across diseases. Next slide, please. So I tell people that I entered lockdown 6 days before the rest of the country. The week before, my university, UCL, like other universities, had released clinical academics to clinical service. And on the 16th of March, the Chief Medical Officer announced a list of high-risk conditions for mortality from COVID, where we should be particularly paying attention to social distancing. The following day, I saw a patient in my heart failure clinic who asked me, why I had been telling him for years that he's much fitter than I am, and now he was in a high-risk category. And it's no accolade to be fitter than me, but I wanted to give him some better personalised information. So I went home and started looking at the data, the resources that we have available. And I locked down with my laptop and spoke to my colleagues who have photographed here. Laura Spiros is looking furtively because I rang him very much over the next 48 hours, and Harry Hemingway. The following 2 days later, the government announced extremely vulnerable conditions, a further 1.5 million people who would be socially isolated. We were in a position on that day to send a preprint to the Chief Medical Officer, which we posted to the server on medRxiv that day. And the following day, we went into lockdown. Next slide, please. So what we did was we took a linked data set of primary care, that's CPRD, hospital episode statistics, and mortality data from Office of National Statistics. And we looked at the high-risk conditions that were listed in the Public Health England document, and we found that there were 1 in 5, 20% of the English population who would fall into this category. And on the right-hand side of the slide, you can see that when we looked at the background or baseline 1-year mortality risk, it varied by the condition and by the number of comorbidities. And also we saw by age and sex. Now that's not surprising based on what we know, but this was the first time that we'd looked at this in relation to COVID. Next slide, please. So using that observation, we specified different age categories and looked at different strata of underlying conditions, and we found that actually the 1-year mortality at baseline is really very variable. You can see the red cells in this heat map, where, for example, in men over the age of 85 with 3 or more comorbidities, you're looking at nearly 30% mortality at 1 year, for example. And the other side of younger people with no comorbidities. So what this showed was there is a need for personalised risk estimates. Next slide, please. So we used that data, which is, if you like, hard data from baseline mortality, and we made assumptions about the policy scenarios and the population infection rates, which is at the top of this slide. We were at that time on 22nd March, just to remind us, there were 81 deaths and 1,950 cases that were confirmed in this country. And we were at the partial suppression stage of the pandemic. And we predicted that if we allowed the infection rate to rise to 10% in a mitigation circumstance, under scenarios where we were looking at the relative impact, so that is how much more does the pandemic add to mortality above and beyond the baseline mortality. If we assumed relative risks at the lower end, at the higher end, sorry, 2 and 3, we would get between 36,000 and 70,000 deaths, and this fed into the decision to go into lockdown. Next slide, please. This was published in the Lancet on 12th of May, and actually in a different scenario, these data are now relevant to how people should or might want to behave in the easing lockdown circumstances. And again, it's this idea of personalising the baseline risk and the risk of excess mortality, and trying to use the best data that we have to drive decisions, and do that in the clearest way that we can. Next slide, please. We released in conjunction with the Lancet paper a prototype calculator, which Laura Passier and Spiros Nexus in particular contributed a lot of hard work to. And this took those assumptions that we made around relative impact and the infection rates, and we allowed people to put in their age and sex, and this tells you the baseline mortality and the number of people like you in England and the number of excess deaths that there might be in that category. We had 350,000 users within 24 hours of putting this online, 500,000 by the end of the week, and over 1 million in the month. So there's clearly an appetite for this kind of specific risk information. Next slide, please. Now, I was one of many clinical academics around the country drafted into full-time clinical during the pandemic, and with my colleague James Moon at UCL, while we were at Nightingale Hospital, we thought that actually what we knew had happened in Italy and in China was that the clinical academic workforce had been eaten up by the COVID pandemic, and so we modelled that under different strain on the system scenarios, using data from NHS England about how many clinical academics there are in England. And you can see that you have about a month or so period where you're nearly without clinical academics if you allow the infection rate to go up. And this feeds into how we've got to be selective, which trials and which studies we choose to do, for example. So this is currently under review. Next slide, please. I know that Jeff Hall, my colleague, is going to be talking about this later, but just to flag that Alvina and Lai really drove this work in our department, where for the first time we were looking at indirect effects. So there are direct effects due to infection, and there are indirect effects which are due to strain on the health system, due to changes in behaviour. And so in this study, they looked at cancer services as well as the model that I've already mentioned. Next slide, please. We have done similar work now in cardiovascular disease that's also in preprint. And so in addition, we have data from the Office of National Statistics. So colleagues Ben Humberston and his team have provided course-specific data. And what you can see is that there's been a spike in total deaths caused by COVID, but there's also been a spike in non-COVID deaths. And we can look at the relative risk and feed that into our models to look at the indirect effect on people with cardiovascular disease, both incident and prevalent, which is what we've done in this study. And I've listed all the many people who've contributed to this work above and beyond the call of duty, and I can't name them all, but very grateful to them. Thank you. Next slide, please. In this cardiovascular disease work, I just want to focus on the middle yellow box here. I won't go through all of this, but we took that Lancet model and we've developed further to think about what do indirect effects actually look like. So 10% infection rate is the baseline infection rate, if you will. And at 40%, there's that direct effect on 10% of people with infection, and as well as a 30% of people indirectly affected. And similarly, we've done the same at 80%. And we found that in England, with cardiovascular disease, that might mean 30 to 60,000 excess deaths directly, but more, 50 to 100,000 deaths excess by indirect effects. Next slide, please. So this work is feeding into more work around specific diseases such as chronic obstructive pulmonary disease, other data sets and other country level data as well. So we've had approaches from other countries interested in this approach. I think the key is that we've been working at pace, particularly Spiros and the Caliber team, to extend our EHR phenotypes to a much wider range of conditions. But also there's now a bigger need than ever to be able to communicate, engage the public in these kind of data. Often we think that we need specific data and we have to be careful what we show the public. What we've shown here is that actually there's a huge appetite right now during the pandemic for better information and in a timely fashion. Thank you very much.
Thank you very much, Ami. So a couple of questions. Firstly from me, on that, can you tell us how you engaged with patients and the public in crafting your online tool to make sure that it was appropriate for users?
So I showed you, Kathy, how tight our timeline was, but even in that timeline, through Sindhuja Manohar and the HDR UK patient panel, we managed over a weekend to get input from 39 members of the public and patients about our tool, which we used. It is a prototype, I said, and so we're still in that ongoing dialogue to improve it and add to the number of conditions. But it's absolutely key to have their input.
Thanks very much. And can you tell us about the international utility of the tool?
So this is a pandemic maybe without precedent, because every country has had lockdown or something similar, and every country is coming out of lockdown or something similar. And that's where individuals, researchers, policymakers, clinicians need this kind of information. So yes, even in our Lancet paper, there was interest for country-specific estimates. So at the moment, we haven't got those age, sex, comorbidity-specific data for each country. So we're working on that. Just today, colleagues at the London School, led by Ros Higo, have published analysis from using global burden of disease data to show that globally it's about the same. About 1 in 5 people are high risk for COVID mortality. So this is an international issue.
Great, thank you very much indeed, Ami. So moving on now, I'd like to introduce Jeff Hall, who's going to speak to us on behalf of the DataCan Health Research Hub.
Thank you, Kathy, and thank you to everybody for joining this session. I'd like to talk on behalf of the DataCan Hub, the hub for cancer within HDR UK. I'm a practicing medical oncologist and an academic within the Leeds Institute's Data Analytics in Leeds, and one of the clinical leads for DataCan. So my next slide, please. DataCan was set up last year, and by desire and design, was a specific attempt to unite cancer data from across the UK. So it's a partnership between some key lead organisations, UCL Partners, where the hub is hosted, Leeds Trust and University, and in Northern Ireland, Queen's University Belfast, which links us in through Mark Lawler's contacts into Wales, and then some very advanced conversations with people from Scotland, looking how we can bring Scottish data. It's set up in partnership with Genomics England and also IQVIA as our commercial partner. And my next slide. And if I had to summarize our strategy on a single slide, it would be very similar to Kathy's description of the British Heart Foundation strategy. We're very fortunate in cancer in having a huge amount of clinical data collected for national data sets. We have estimated that that takes approximately 10 to 15% of the electronic health record on any individual patient. And therefore, what we'd like to do is improve the depth and breadth of data that is made available and link data with natural language processing of the plain text of a clinical record, but also the application of AI and machine learning to digital radiology, digital imaging, and then through Genomics England, our ability to bring in genetic and molecular phenotypes to the data set we're using. And of course, like everybody else within the HDR UK family, we're looking to improve access to clinicians, academics, and commercial organizations who wish to access that data. We wish to improve the quality of data that we're collecting, and then perhaps most importantly, ensure fair value for the NHS, for healthcare organizations and patients. Next slide. So as COVID-19 began to have its impact on the UK, the hub began to discuss the potential link between COVID-19 and cancer. And we discussed that in ways that very much reflect what Ami has described. So we were very clear that there would be a two-way relationship between COVID-19 and cancer. So the questions we were asking is, what is an individual's cancer? How is an individual's cancer going to affect their risk of COVID-19 infection? And if they were to catch that infection, how would that dictate its clinical course? We were also interested to know what the impact of a tumor site and a patient's underlying comorbidity would have. But also there's a flip of that, which is what was actually the COVID-19 infection and in an individual going to have on the cancer. So the cancer treatment would be changed, and clearly the cancer outcome could be affected. But the indirect effects we think are very significant. So what is the impact of the COVID-19 pandemic on cancer services across the country? And Mark Lawler began to work with colleagues across Europe, and in April published this paper in the European Journal of Cancer, which includes a sentence which I recognize from my own practice, that patients were beginning to fear a COVID-19 diagnosis more than their established cancer diagnosis that they were already under treatment for. Next slide. So we began to work with the research group at UCL, with Ami and his team, and he's already described the ability of that team to examine the health records of just short of 4 million patients within the Calibre dataset, which is a primary care record dataset linked to ONS. And from that dataset, they are able to identify two cohorts of patients, patients with a cancer diagnosed sometime previously, and also a more recent diagnosis of cancer, which had allowed us to classify them into both incidence and prevalent cancer cases. And then in the top right-hand side of this slide, we examined the incidence of individual comorbidities, the 15 comorbidity phenotypes that Ami and his group have defined in each of the 24 most common cancers. We also then were able to examine the one-year mortality for each tumor site within those datasets, both once again for prevalent and incident cancers, and then look at the interaction between a tumor, its comorbidity, and the outcomes, and from that begin to model the impact that a direct infection of COVID-19, and this is where if 10% of cancer patients are infected with a relative risk of 2, we're projecting just over 3,000 excess deaths within the cancer patient population. Next slide. So what we were also keen to look at was the indirect effect. What was the effect of the COVID-19 pandemic on cancer services? And once again, through ongoing work with the HDR UK Centre in London, we began to discuss looking at data for both urgent referrals and for chemotherapy activity. What I would suggest are two different ends of a cancer patient's journey. We got data from a number of centres across the UK in Leeds, London, and all of the hospitals of Northern Ireland. And on the left-hand side on the figure on the right, we saw an incredibly consistent drop in the urgent referrals. So a 76% reduction in urgent referrals, and then a more varied reaction in chemotherapy attendances across hospitals across the country. But using this data, once again, we can model the indirect effects. And this is where our concern for somewhere between 6,000 and 17,000 excess deaths in cancer patients that could result from either delayed diagnosis or altered treatment. Next patient. Sorry, next slide, please. So I'll go back to this point, the remarkable consistency. When we first pulled this data from Leeds, I was really concerned I was looking at a Leeds-specific effect. But when the data started coming in from other centres, it was amazing how consistent the drop in urgent referrals was across the whole country. And I think that this probably reflects the fact that this is the public reacting and responding to that one single clear message that we heard each day at the 5 p.m. briefing to stay at home. And patients stayed at home. They stopped contacting their GP, and their GP stopped referring them. But on my next slide, I think we did see more variation in chemotherapy activity. And I think this reflects the fact that this is a local response. This is an individual hospital being able to judge the COVID-19 impact in their own hospital. When I was describing the 50% drop of activity in Leeds, I spoke to a centre in Scotland who was still continuing all chemotherapy. But at that time, they had 3 COVID-19 inpatients, and we had 250. And therefore, it's entirely appropriate for a local response that reflects the local problem. Next slide. So we, like Kathy and the British Heart Foundation, are desperately keen to examine the wider impact of COVID-19 on cancer services across the UK, and there's a range of data that we need. The urgent referrals, we'd love to see that across the UK, but what will happen, we believe, is also a reduction in cancer waiting time performance. So many patients are having a delayed diagnostic pathway. At the moment, we're beginning to see the first signs of a reduction in the numbers of cancer diagnoses. Of course, the nature of the disease is those cases will eventually present, but they'll present at a more advanced stage, and they'll present as an emergency presentation, which we know is associated with a worse outcome. We're expecting to see some differences in the use of surgery, chemotherapy, and radiotherapy. And unfortunately, as we track this over time, we will begin to see the negative impact on 1 year, 2 year, and 5 year outcomes that our patients achieve. So what we're looking to do is use current data sets. Can we agree common single data models and get centres across the UK? On the right-hand side here, this is data that I pulled from the public website for English 2-week wait data, which on June the 9th, when I was preparing these slides, included March's data. But on my next slide, 2 days later, the country published its 2-week wait data to April. And that is where the news hit last week about the 65% reduction in 2-week wait data. But on my next slide, this is the data that is available from an individual trust. So this is again Leeds data, which once again shows this dramatic reduction in activity over Christmas, a spike of higher activity to catch up after Christmas. And then from late February through March and April, this dramatic drop in urgent referrals, which had slowly begun to return. You can see the negative impact that a 4-day week has on cancer referrals, and also crucially the fact that we're not back at steady state yet. So Leeds are currently estimating that we're about 3,500 cancer referrals down, and we reflect about 1% of the country's cancer referrals. So the fear is that there is about 500,000 patients out there who historically would have gone for a 2-week wait assessment, who've not gone through that diagnostic process. Next slide, please. So the work that we've done here was a true coming together of the minds that sit within DataCan and the great minds that sit within the HDR UK Centre at UCL. I'd like to particularly call out the amazing work that Alvina performed in this study, and I would also draw your attention to the fact that she is one of the lightning talks later on this afternoon. But my thanks also to Amy and Harry, and specifically to the trust who provided the data which enabled us to look at this problem in greater detail. Thank you very much.
Thanks very much, Jeff. Extremely interesting, and I can see a couple of questions building up. I'm going to park those and keep them for the general question and answer session later, just in the interest of time, and ask our third speaker now, Jenny Quint, to let us know about the activities of the Breathe Hub.
Great, thank you very much, Kathy. Thank you to all of you for being here, and thank you for the invitation to speak. So I'm very much talking on behalf of a huge collaboration. Can I have the next slide, please? And just to start with, I'll just give you an overview as to Breathe and what we're all about. So the whole sort of ethos behind Breathe is about improving respiratory health for the general population by improving access to data, be that data sets that exist already, helping to shape new data sources as they come to fruition, and also in the linkage of data sources that exist. So it's all about improving access and quality, very much with patients at the heart of all of that to improve respiratory care. So the hub is led by Aziz Sheikh, who's based in Edinburgh, and I'm the Deputy Director. Katie Kizik is our Chief Operating Officer, and you can see from this slide that we've really split things into 3 main themes, and these are our green pillars there. The first one being around drug discovery and pharmacogenomics, which is led by Martin Tobin and Ian Hall. Real world evidence, which is led by myself and Chris Griffiths, and digitally enabled trials, which is led by Aziz and John Norrie. And then we've got 3 strands which underpin absolutely everything that we do. So the first being patient and public engagement and involvement and all of our communications around that. The second being around partnerships and sustainability. And the third, and possibly most important underpinning all of these is data and how we have data in a trusted environment through the SAIL data bank and are able to improve access to data. Next slide, please. So I'm just going to very briefly talk about some of the ways in which Breathe has been involved and led on research around COVID. So first of all, with public and patients at the heart of everything we do, to say that our 2 lay leads, Anthony and Alex, have been very heavily involved, not just in work that Breathe has been doing around COVID-19, but also contributing to other HDR UK activities. So they both sit on our executive and on our scientific committees, so inputting into new studies as they're discussed and developed, and also processes as they arise. And you can see here, as Amy had been referring to, he'd had a little bit of patient feedback in terms of developing the app. So our patients were very much involved in that and in wider HDR UK activities. And of course, it goes without saying that with so many clinicians involved in Breathe, we all have access to local patient populations through our individual hospitals, and also members of the Sale Data Bank Consumer Panel are part of the information governance review for studies there. So very, very heavy patient and public involvement. Next slide, please. So just talking very briefly then about the work that Martin and Ian have been leading on and involved in regarding drug discovery and pharmacogenetics. So Martin, when he was helping me put the slide together, said that I should describe him as the glue to a lot of projects. And I think that can be said for all of the work that I'm going to present. So they've very much been involved in helping with the Wellcome Trust with Mary De Silva around the longitudinal population study coordination. So, for example, around harmonisation of questionnaires relating to COVID-19 risk, and also some interest around exposures and consequences. And these questionnaires are in the process of being implemented through a number of the longitudinal cohorts. Martin is the PI of the Exceed cohort and has been able to, I guess, readdress some of that focus to focus specifically on COVID-19 research. And I've just put a few examples there of the types of things that he's been interested in looking at. So specifically around BAME, around some questionnaire work, and around data linkage to be able to answer new questions in addition to those that have arisen already, and sample collection as well. And then they're also, Martin and Ian are also involved in international collaborations, and I put one example down here around the Corona Gene study. That's an international genomic initiative specifically around COVID-19. Next slide, please. With respect to real world evidence, we've been working very closely with a number of existing data controllers. So with Open Safely, for example, around some of the specific COPD and asthma work that they're undertaking at the moment, around some of the other wider HDR UK sites. Ami and I have been in discussion about taking some of his work and specifically looking at respiratory populations, so people with asthma and COPD. We've been involved with some of the work with Discover Now, so collaborating across hubs on respiratory disease. And I've been bombarding Spiros with codeless and algorithms for phenotypes for respiratory specific diseases, not just related to COVID, but that go beyond COVID-19 that may well be of interest to people as they're looking at these diseases in the future. One of the things that we spent an awful lot of time on and energy on in the last few weeks has been around the Zoe and the King's College London C19 Symptom Studies app. The Sale Data Bank is hosting in partnership with Breathe the Zoe COVID-19 Symptom app data. And you can see here that as of the beginning of June, we'd had over 100 inquiries for access to the data, with 33 projects approved to access the data. And we've not just been providing access to the data, we've been helping in terms of data curation, in terms of data analysis, and also undertaking analyses internally to Breathe, which are then being fed into government and SAGE committee and modelers, etc. And we're also in the process of facilitating linkage to Welsh NHS records to look at a more complete picture beyond just the symptom app data. Next slide, please. With respect to the digitally enabled trials, so Aziz has been leading in Scotland on the Confidence UK study, which is led by QMUL, and there are a couple of other trials which have recently started. One is EVE2, which is looking around patient data to track the progress of COVID-19 in near real time across Scotland, and the other one, Elvis, is looking at the use of a saline solution to reduce early symptoms and progression of disease. Next slide, please. And we continue to work very closely with HDR UK and the Alliance and the Workbench, and this is something that I believe Andrew Morris mentioned very briefly earlier, and we are very much involved in new projects that are going forward. Next slide, please. I'm happy to take any questions.
Thank you very much, Jenny. And so now just to open up for questions across all of the talks, and we invite you to submit those through the Q&A function. I'm going to hand the chair back over to Sarah to chair our Q&A session. Thanks, Sarah.
Thank you, Kathy, and thanks to everybody for your talks. I have one question, given my personal background, one question for each of you, but I do notice that we've had a few questions coming in actually in relation to a couple in relation to cancer, and one generally actually from Caroline Cake, so I best ask that one at some point. But if I could maybe just start with you, Jeff, just on one of the questions that came through early on actually in relation to your talk, that post-COVID, do you think that cancer may increase in those who've had COVID or COVID complications? Are there any indications at all from what you've seen that might be the case?
So I'm not aware of any data that can currently answer that. I've seen no linkage of cancer diagnosis data to COVID PCR results. I think that it'll be interesting to see whether that does come out. I mean, what will also be quite interesting to see is the impact that a COVID-19 infection actually has on cancer outcomes, because patients may do badly, but I'm intrigued by the fact to consider the immune response to a COVID-19 infection and actually what that might actually do to a patient's immune system reacting and responding to their own cancer. And as the increasing data comes out about COVID-19 perhaps being an infection of vascular endothelium, actually, if the tumor endothelium is perhaps one of the most dramatic differences in normal tissue, what is the potential of a COVID-19 of tumor endothelium? So perhaps I'm hugely wishful thinking, but is COVID-19 going to turn out to be a positive for some cancer patients? Who knows? But let's watch that and track that.
I think that the question from Caroline actually maybe could potentially go to each of you. So the question is, given the lessons that you've seen across cancer and CVD and respiratory disease, what new data sets and data set improvements do you think need to be prioritized by hubs? So I don't know if I could ask you, Ami, for your views first, and then it'd be interested to hear from each of you if you think there are any that we particularly benefit from at the moment.
I think Caroline's right on the money with this question, that we can't afford to think about this disease by disease in our silos. We have to have an approach that's different. So everybody with respiratory disease is at risk with multimorbidities, same for cardiovascular disease, same for cancers. So we can't afford to recreate this every time for each disease. I would say that the hubs are well placed to look at how we get timely primary and secondary care data that's not that's near real time and not retrospective like a lot of what we've been doing in our research group, so that we can look at those indirect effects in particular. And Kathy and others, and we just talked about Jenny as well, and DataCan are looking at gathering a national observatory type model so that you have a selection of hospitals and settings that can provide that data. But there's no reason that we can't do this. We're actually really well set up to do that in the UK, so we should be doing that.
Thanks, Annie. I don't know if Jenny, you had anything to add at that point?
Yeah, so I think we have a phenomenal amount of data that exists already that I don't think we use to their full advantage at the moment. So I think we could do much better with things that we've already got, particularly in terms of being able to link data sets and being able to facilitate access to answer those cross-disease questions in other specific data sets. I think if any new data really are missing, it's around the detailed information to pull out of secondary care in the same way that we can out of primary care records to that sort of degree. But I think we can do a lot more with what we have already.
Yeah, the only point I would add is to repeat the view that we already have an enormous amount of data, and the hospital was struggling before February to collect all of the data that the central beast wanted to be collected. But we should be reusing that. We should be using that data to its maximum value. And at the moment, we're not using that data to its maximum value. It is in cancer, we have to wait a significant amount of time to be able to access data. So we need data that is collected at source as a consequence of care, not as a separate activity. We need it in real time, and we need to bring it together with others who are willing and able to do that. So I think this idea of these national observatories that can bring data sets together and describe the activity of last week, not the activity of 2 months ago or 2 years ago, which suddenly feels deeply out of place in an old-fashioned approach, which no longer serves any useful function.
Thank you. Couple of questions have come in, but actually I will ask this of any of you. Basically, are any of the projects looking at collecting or linking data from social care?
I can say that we're not at the moment, but there are people in our institute at UCL who are in detail looking at care homes and social care, and so we're looking to link with them, but we've not done that yet.
So yes, this is something that Breathe is doing around data sets that exist in Scotland and in Wales. Seems to be harder in England to put that piece of the puzzle together.
Thank you. I think the slightly linked there it is. Sorry, couldn't find it. In terms of indirect effects, has consideration been given to social determinants of health as well?
So I think that's really important in cancer data. I'm fascinated to see who has stopped coming for a cancer referral. Has it been equally applied across society, or are we actually seeing once again something that will have a greater, more negative effect on lower socioeconomic class? How will it affect people of different ethnicity, different backgrounds? How will it affect across the age? So I think there's a bunch of social determinants that are going to need to be taken in as variables in the analysis we do. I think at the moment, I'm delighted that we're doing a very simple descriptive of total numbers, but I think that there's much greater interest in the detail of this as we get better able to collect this data. It will allow an ever deeper explanation and understanding of the problem.
Can I add very briefly that
Yes.
Actually the ONS, Office of National Statistics, is doing some great work in terms of the weekly updates, providing national data, which it would be great for us to be able to link to our own work. So I'm talking about, for example, in ethnicity, they've been able to link with census data and start looking at number of people in households and linking that with age and so on. So I think we have to think across data sets.
Thank you very much. I am acutely aware of the time at the moment. So sadly, as I said before, we do have contact details for anybody who had burning questions that we didn't manage to get around to answering. So please feel free to send those questions direct. But can I just take this opportunity of thanking everybody for participating, and thank you everybody for joining us. Hope you enjoyed it.